Thank you so much for giving me the floor. On behalf of TB Speed Study Group, I'll present the impact of decentralization of childhood TB diagnosis to district hospital and primary health center. While WHO estimated that 1.1 million children will be sick with tuberculosis, only 54% were notified by national programs, and mainly due to difficult to diagnose TB in children, and TB services mainly available at high levels of care. WHO recommends bringing child and adolescent TB services nearer to the communities, and it's important to note that Uganda has already extended some of these services to the lower health communities. However, childhood TB is still not well identified at the lower health facilities. There are several challenges that need to be considered in decentralization, and there are limited ability at peripheral level for TB screening, specimen collection and rapid molecular testing, taking and interpreting chest X-ray, and deciding to initiate TB treatment without microbiological confirmation. An innovative diagnostic approach was proposed by TB Speed Consortium to standardize and facilitate the implementation of child and adolescent TB care at peripheral health care level. And this childhood TB diagnostic approach involves the following components. One, systematic TB screening that was done for every child arriving at health facilities for care, and we used standardized questions. And we also conducted clinical evaluation using a specific algorithm and mentorship. We also did microbiological diagnosis using expert on ultra and nasopharyngeal aspirate. And we also had digital chest X-ray using standardized approach. It's important to note that all these components of the innovative childhood TB diagnostic approach, some are new or others are a little bit improved to be able to increase some of the, or improve the care of TB at health facilities. This innovative TB diagnostic approach was implemented into decentralization strategies. One, the district hospital focused decentralization strategy, and two, primary health center focused decentralization strategy. I'll present the flow of a patient when they arrived at primary health facilities until they reach the district hospital. And also just describe briefly the activities of the approach that were implemented in the two strategies. When we look at the district hospital focus strategy, we see that at primary health facilities, there was systematically screening, so every child who arrived at primary health facility would be systematically screened and then referred to the district hospital for diagnosis. And when we look at the primary health center focused strategy, we see that all the other components of the diagnostic approach were taking place from the primary health facilities, and the patients would be referred for chest X-ray at the district hospital if they still had symptoms at day 7. And it's important to note that the other components of the diagnostic approach were all taking place at the district hospitals in the two different strategies. And to test the impact of the innovative approach, TB Speed conducted a decentralization study. It was an operational research in 6 countries, including Uganda. And each country had 2 districts. And the districts in Uganda were, Rakai implemented a district hospital focus strategy, and Kanungu implemented a primary health center focus strategy. Of course, to answer the question, we had to assess the effect of the innovative diagnostic approach on TB case detection, and also assess the uptake of the innovative diagnostic approach. And we also assessed the feasibility and acceptability of this diagnostic approach among healthcare professionals. We compared before and after routine data to assess the effect, and also enrolled a cohort of children less than 15 years with presumptive TB to assess the uptake of the diagnostic approach. We also had qualitative study to assess the feasibility and acceptability of this diagnostic approach. The results, because this was a multi-center study, I'll first show you briefly the results from the overall 6 countries, and after that, I'll focus on Uganda. When we look at the effect of the intervention in all the 6 countries, we see that there was an increased number of case detection from 0.08 to 0.2, and this increase was more seen at the district hospital focus strategy. However, because of collection of overdispersion, it was not statistically significant. Focusing on Uganda now, we see that there was no difference pre-intervention and post-intervention, as well as between the 2 decentralization strategies. When we look at the uptake of the nasopharyngeal aspirate and stool collection, and then use of the expert ultra, we see that from the 732 children enrolled in the study, 99 had NPA collected, and they had a valid result with a yield of 12 TB cases detected. For stool, we were able to collect 76%, and 73 had a valid result, and then with 4 TB cases detected. When we look at the TB diagnosis among enrolled children by strategy, we see we had overall 43 cases of TB, and we see that the majority were clinically diagnosed, or they had a chest X-ray that was TB suggestive. The acceptability and feasibility data, we note that all the components of the diagnostic approach were positively perceived by the healthcare workers. However, some had a few issues. For example, systematic screening, some parents were not able to understand some of the screening questions, like weight loss and contact history. And when you look at the NPA could cause some discomfort, and sometimes it would be traumatic. For stool collection, there was delays of area in stool collection due to cultural practices and some distances from the health centers. When you look at the chest X-ray, there were delays in accessing digital images at primary health centers. And for ultra testing, the healthcare workers in the primary health centers, they were frustrated by the turnaround time of the large number of samples at the facilities. In summary, therefore, we see that the innovative TB diagnostic approach at low facility level increased detection with higher potential for district-focused strategy. However, this effect was less evident in Uganda, and we think it was because of the partially decentralization that was already existing. Decentralizing the 4 components of innovative childhood TB diagnostic approach was feasible and acceptable to the healthcare workers in all the facilities. However, there were some feasibility challenges that were noted in stool collection. And there's a new WHO proposed treatment decision algorithm for pediatric TB. It's to be conducted by Epicent in a multi-center study. We believe that it will provide more findings on childhood TB. Thank you so much for listening, and I would like to thank the funders and the sponsors and all the collaborating partners that implemented the project.